Dr. Hicks, Dr. Jorgensen, ladies and gentlemen. I have nothing to disclose. I'll be hitting only the high points on this presentation in the interest of time, so this is peer-reviewed and available for review. We know that the incidence of peripheral disease has exploded with our increasing age of our population and incidence of diabetes. Interventions for peripheral disease double every decade. CLI forms a very small percentage of patients with PAD with a pretty dismal outcome, which really hasn't changed over the years. Most interventions, therefore, today are being done for claudication. In 2008, CMS introduced outpatient payment for peripheral procedures, and the OBL was born. Today, most peripheral procedures are being done in the OBL, and atherectomy is certainly the most frequently done there. This massive increase in PAD procedures in the OBL has not resulted in the cost savings that was originally envisaged. This is a retrospective analysis of VQI data from 2011 to 2020, linked with survival data from Social Security Death Index. PAD interventions were classified as balloon, stent plus or minus balloon, or atherectomy plus or minus stent and balloon. Patient characteristics and comorbidities were recorded, and the site of the intervention, femoropopliteal tibial or aortoiliac, was recorded. Primary outcomes were survival following intervention to the most recent follow-up. Secondary outcomes were the usual in-hospital mortality, length of stay, vascular-specific complications, unplanned amputation. We performed propensity score matching with a ratio of 1:1 and implemented to construct 3 matched cohorts to compare balloon versus stent, balloon versus atherectomy, and stent versus atherectomy. We calculated Kaplan-Meier estimators for overall survival. We used univariable and multivariable analysis. And after propensity matching, we had approximately 3,000 patients between balloon and stent, about 2,000 patients between balloon and atherectomy, and about 1,600 patients between atherectomy and stent. The cohort was about equally divided between claudicants and CLTI, and male-female ratio was 60-40. The vast majority of these patients were Caucasian, and the breakdown for femoropopliteal versus aortoiliac was about equal between balloon and stent, but wherever there is atherectomy, as you might imagine, it's mostly in the femoropopliteal segment. Most of these procedures were done electively, and there were really no differences in the comorbidities between the 3 groups. And here are the results. When comparing stent versus balloon angioplasty, hazard ratio of 0.7 or 30% better survival with stent compared to balloon. And in the middle column, you'll see atherectomy versus balloon. There was no difference. And stent versus atherectomy, hazard ratio of 0.6 or survival 40% better with stent rather than atherectomy. There were no other differences in any of the other categories listed. In-hospital mortality, length of stay, secondary outcomes were no different in the 3 arms. Between claudication and CLTI, huge differences in the claudication group. As you can see, hazard ratio of about 0.5 and 0.55 in favor of stent versus balloon and atherectomy, and no difference between balloon and atherectomy. The CLTI, they did not reach statistical significance, although it tended towards significance. When shown in Kaplan-Meier estimates, you can see these graphs clearly show the difference between balloon and stent in the claudicant, no difference in the middle, and again, a huge difference between atherectomy and stent. When broken up between CLTI and claudication, you can see the differences in the claudication group with very little difference in the CLTI group, although tending towards significance in the atherectomy versus stent and CLTI. Obviously, these are observational studies and they have huge limitations. We know that the group from Kentucky has shown us that the revascularization of intermittent claudicants leads to more chronic limb-threatening ischemia and higher amputation rates. We know that this paper from Dr. Bath shows that most endovascular interventions for claudication do not meet minimum SVS standards. We know from other investigators using VQI data that atherectomy has a much higher amputation rate and major adverse limb event rate. Mortality from medical management of intermittent claudication has been extremely low, and this is well documented over the years in the literature. The Cochrane review and many other reviews have shown that there is no advantage of atherectomy over balloon angioplasty alone at any time. And most recently, Dr. Hicks from her and her group has shown that when atherectomy is the primary procedure for claudicants, reintervention rates are much higher. So, ladies and gentlemen, this is a retrospective analysis of prospectively collected data showing that stent and had a 30% better survival than balloon angioplasty and 40% over atherectomy. There was no difference between balloon and atherectomy. Secondary outcomes were similar. Expensive interventions do not necessarily correlate with good results. What has been good for the bottom line of the OBL may be fatal for the patient. We recommend a critical reappraisal of the treatment paradigm for PAD patients presenting with claudication. We believe that the current CMS reimbursement for atherectomy has resulted in unintended consequences. Thank you.
We have time for one question.
Dr. Mukherjee, I don't remember your disclosure slide, but you're not receiving any support from the atherectomy companies, are you?
Deeply conflicted.
No, my question relates to the propensity matching. Did you also do that for anatomic criteria, length of stenosis, calcification, et cetera?
For secondary outcomes as well, yes.
All right.
My question was sort of about attribution. Is it fair to attribute sort of survival to a procedure, a PVI procedure?
Sorry, say that again.
So can you really sort of suggest that your PVI intervention that you did resulted in survival differences over 3 to 5 years, which is what the Kaplan-Meier curves are showing?
Yeah, so I think that there is precedence for this. If you look at the coronary literature, we know that patients who had primary stenting after AMI, acute MI, their outcomes were much better than those who had initial balloon followed by stenting. And the reason is obviously that they have distal embolization, which is much more the case with peripheral interventions. And there is enough MRI data to show that those who may have had balloon first followed by stent, they have much more myocardial tissue death, which subsequently leads to CHF and ventricular arrhythmias and ischemic cardiomyopathy and a much higher mortality over the years. So these are not changes that you will see immediately, but when you follow them out 3, 4, 5 years, as you said, that's when you start seeing the changes. And I believe that we're seeing the same thing in the peripheral circulation.
Great. Thank you.